A dissecting aneurysm is a progression of a false aneurysm. As blood continues to fill the vessel wall, the layers of the wall separate longitudinally to create a blood-filled cavity. The most serious complication of aneurysm is rupture. If the posterior aspect of the aorta ruptures, bleeding is somewhat limited by the pressure of the surrounding tissues. Classic signs and symptoms of rupture are severe back pain and ecchymosis of the back or flank, called Gray-Turner sign. If the anterior aspect of the aorta ruptures, however, the abdominal cavity provides less pressure to control the bleeding. Hypovolemic shock quickly develops, and these clients usually die before rescuers can intervene. What are the risk factors for aneurysm? Arteriosclerosis and hypertension are thought to contribute to the development of aneurysms. Plaque formation causes the middle layer of the vessel to deteriorate so that the affected portion eventually stretches and weakens. Hypertension also contributes to the degenerative process. There also appears to be a genetic predisposition. Although less common, some aneurysms are caused by trauma, connective tissue disorders, and failure of graft anastomosis. Do you remember the signs and symptoms? Because most abdominal aneurysms are asymptomatic, most are discovered incidentally or during routine examinations. On palpation of the area around the umbilicus, a pulsating mass can be felt to the left of the midline. Auscultation of the mass reveals a bruit. When symptoms do develop, they are usually related to compression of the structures near the aneurysm and include back pain and epigastric discomfort. If plaque fragments break loose and block distal vessels, an arterial occlusion will be seen as white, painful area on the skin. Plaque can also block mesenteric or spinal artery flow, causing infarctions in these areas. Aorta aneurysms are often discovered on radiographs or scans done for unrelated reasons. When an aneurysm is found or suspected, a CT or MRI may be done to identify the exact location, size, and severity. Angiography helps the physician determine which, if any, vessels other than the aorta are involved. Let's talk about management of an aneurysm. If an aneurysm is less than 4 centimeters in diameter, it is treated conservatively and monitored for enlargement. Conservative treatment involves lowering blood pressure to reduce pressure on the stretched vessel. Surgical intervention is required to repair larger aneurysms and to prevent rupture. Elective repair carries a much lower mortality rate than a repair after a rupture does. Conventional surgical repair of a fusiform aneurysm involves incision of the affected portion of the aorta, removal of thrombi and plaque from the lumen, placement of a synthetic graft, wrapping the aorta around the graft to protect it, and suturing the aorta. A saccular aneurysm can sometimes be repaired by excising the pouch and closing the defect with sutures or a patch graft. For either procedure, the aorta must be clamped above and below the defect. If the aneurysm involves the renal arteries, or the clamp must be placed above them, there is a risk of renal complications. There is also a minimally invasive grafting technique that is an alternative to the conventional approach. It can be used only when there is no renal artery involvement. A sheath enclosing a cylindrical graft is passed into the aneurysm through the femoral artery, and a balloon is inflated that presses the graft against the vessel walls, where it is secured with small hooks. Then, relieved of the pressure, the dilated vessel eventually shrinks. Leakage of the graft is the most common complication of minimally invasive grafting. Other complications are aortic dissection, bleeding, graft thrombosis and embolization, and renal artery occlusion caused by graft migration. So what is the nursing care for a client who has an aneurysm? When an aneurysm repair is done as an elective procedure, you would implement standard preoperative care and teaching. You would document baselines for vital signs, peripheral pulses, and neurologic status. Marking pedal pulses and skin lesions before surgery will facilitate postoperative assessment. The client must be monitored for any signs and symptoms of rupture, as described earlier. Explain that clients usually go to an intensive care unit immediately after this type of surgery. Prepare the client for an endotracheal tube, a nasogastric tube, an indwelling catheter, and various intravenous and monitoring devices. Male clients commonly experience sexual dysfunction after abdominal aneurysm repair. The surgeon should explain this to the client preoperatively. If the client wishes, a referral to a urologist should be made to identify options to improve function. While awaiting surgery, the client may be on antihypertensives to reduce pressure on the aneurysm. Postoperatively, assessment that is specific to aneurysm repair focuses on graft patency and integrity. Because good hydration and normal blood pressure are required for graft patency, CVP and PA pressures should be monitored in addition to blood pressure. Renal perfusion is also essential. To assess for renal ischemia, monitor hourly intake and output, daily weights, CVP and PA pressures, and daily BUN and serum creatinine measurements. To assess cardiovascular status, monitor the ECG for dysrhythmias, and check serum electrolytes and arterial blood gases. Be alert for symptoms of myocardial infarction, and be sure to assess peripheral pulses. To assess neurologic status, monitor sensation and movement of the lower extremities. For gastrointestinal function, check bowel sounds, because paralytic ileus is common. A rare complication is an ischemic or infarcted bowel, manifested by the absence of bowel sounds, plus fever, abdominal distension, diarrhea, and bloody stools. To monitor for infection, check body temperature and WBC count, and inspect the incision for any sign of infection. The nursing diagnoses include ineffective peripheral and renal tissue perfusion, risk for infection, anxiety and fear, and sexual dysfunction. Because hypotension may result in thrombus formation in the graft, good hydration is vital. Administer IV fluids and blood components as prescribed, and closely monitor the rates of infusion and pressure measurements. Why is maintaining blood pressure so important? Well, it's really a balancing act. Hypotension may lead to stasis of blood and development of clots that can occlude the graft. On the other hand, hypertension must be controlled because it can induce leakage by placing excessive pressure on the graft. So maintain systolic pressure at about 100 to 120 millimeters of mercury with antihypertensives like nitroprusside, trade name Nipride, or labetalol, trade name Normadine. Administer diuretics and antihypertensives as prescribed for severe hypertension. Be aware of any conditions that increase the cardiac workload. Treat pain and hypothermia or fever. Administer oxygen, antidysrhythmics, and electrolyte replacements as prescribed. Reassure and comfort the client. Inform the surgeon of any change in warmth, color, sensation, or movement in the lower extremities. Initially, check peripheral pulses hourly. For a short time after surgery, distal pulses may be absent due to vasospasm. If the graft becomes occluded, surgical intervention is required. Irrigate the nasogastric tube as indicated to assure proper drainage and to prevent abdominal distension. Document the return of bowel sounds and the passage of flatus. To reduce the risk of infection, keep the incision clean and dry, and use aseptic technique with invasive procedures and equipment. Administer broad-spectrum antibiotics as prescribed. To reduce anxiety and fear, simply explain what is happening and what you are doing. The teaching plan that prepares the client for discharge should include assuring your client that it is normal to feel very tired at first. Tell him that he can gradually increase his activities as tolerance improves. To avoid heavy lifting, usually for 4 to 6 weeks, as instructed by the surgeon, and to notify the surgeon if he has a fever, incisional redness, swelling or drainage, increased pain, or changes in pulses, color, and sensation or warmth of the extremities. Our next cardiovascular topics are peripheral arterial disease and femoral popliteal bypass grafting. Managing peripheral arterial disease encompasses lifestyle changes, measures to protect affected extremities, drug therapy, invasive non-surgical procedures, and surgical procedures. What are the indications for surgical intervention? Surgical procedures are reserved for clients who experience severe pain at rest, claudication that interferes with work, or circulatory compromise so severe that there is a danger of loss of the limb. The femoral popliteal bypass procedure can be done under general, epidural, or spinal